Good afternoon, ma'am.
We welcome our.
Hello, good afternoon.
Yes.
Can you hear me?
Yeah, here. Your voice is audible.
Great. Just let me know when you're ready for me to share my screen and to get going.
Dr. Danieli.
Yes.
Just a minute. You unmute your audio. Unmute your mic.
Can you hear me?
2 seconds.
Sure.
Now I welcome our Honorable Secretary, Madam, Dr. C.A. Vasigi, ma'am. Welcome, ma'am. Ma'am?
Yes. Thank you very much.
Can
you hear me?
Yeah.
Yes, you are audible. You are audible.
Okay. Great. Are you ready for me to start or?
We can start just after 5 minutes.
Okay, no problem.
Now I welcome our Honorable Secretary, ma'am. Ma'am, good afternoon, ma'am.
Yes, good afternoon.
Good afternoon. Start from
Shobana?
Yes, ma'am. Okay, ma'am. Okay, ma'am.
So, dear participants, we welcome you all to the virtual guest lecture. So, before begin the session, we would like to request you all to please mute your mic and close your camera. So, we request all the participants, you please mute your mic and close your camera. And during the session, due to the internet difficulty, if you go out of the session, you please join with us in the YouTube live link. We request you all to join with us in the YouTube live link. If you go out of the Google Meet due to the technical issues.
A very good afternoon to everyone present here. Myself, Dr. C. Shobana, Assistant Professor, Department of Zoology, Kongunadu Arts and Science College, Coimbatore, India. On behalf of our management, organizing committee, I welcome you all for the International Virtual Guest Lecture on Theranostics Approaches to Cancer Management, organized by Department of Zoology, Kongunadu Arts and Science College, Coimbatore, India. So let us start the program with Welcome the Gathering. Now it's my pleasure to invite our Honorable HOD in charge, Dr. S. Dinukumari, ma'am, Assistant Professor, Department of Zoology, Kongunadu Arts and Science College, to deliver the welcome address. Ma'am, please. Ma'am?
Oh, okay.
Okay.
A very good afternoon to one and all present here. I am extremely honored to have the opportunity to address in this prestigious moment. It gives a great pleasure to welcome all participants attending this International Virtual Guest Lecture on Theranostics Approaches to Cancer Management, organized by Department of Zoology, Kongunadu Arts and Science College, Coimbatore, India. It gives me great pleasure to extend a very warm welcome to our esteemed Honorable Secretary and Director of our college, Dr. C.A. Vasigi Madam, distinguished Principal Dr. M. Lakshmanasamy Sir, respected Dean R&D Dr. Palasamy Sir, and Dean Academics Dr. Madan Shankar. Welcome you, sir. A hearty welcome to today's resource person, Dr. Danieli Merrick, Genesis Care Oncology, Theranostics, Australia. Welcome you, madam. And also, I extend my warm welcome to all faculty members, scholars, and students of Konganada Arts and Science College and participants from other institutions for their active participation to this virtual guest lecture. I once again, on behalf of the Konganada Arts and Science College and on my own, I welcome you all to this virtual guest lecture on diagnostics approaches to cancer management. I wish everyone to have a great time with us today. Thank you.
Thank you, ma'am, for your welcome address. Now I am very much, thank you, ma'am. Now I am very much happy to invite our principal, sir, Dr. M. Lakshmanaswamy, Konganada Arts and Science College, Coimbatore, to deliver the inaugural address. Sir, please, sir.
Thank you, Shobana. Good afternoon, one and all present here. Most respected Secretary and Director, Dr. C. A. Vasagi, Madam, and our resource person, Dr. Daniel Merrick, Genesis Care Oncology, Theranostics, Australia, Convener, Dr. S. Binukumari, Organizing Secretary, Dr. C. Shobana, and the organizing committee members of the Zoology Department, research scholars, PG students, and participants. On behalf of the management, once again, I welcome you all, and also I'm very happy to inaugurate the international virtual guest lecture on diagnostic approaches to cancer management. So, being a biologist, I want to say something about the cancer. Actually, the diagnostic approaches are for the cancer types, mainly the bladder cancer, that will the affected part is the urinary bladder, and the breast cancer, milk ducts and the lobules, colon cancer, large intestine, lung cancer, any part of the respiratory system, endometrial and uterine cancer, tissue coating the uterus, kidney and renal cancer, kidney, thyroid cancer, leukemia or blood cancer, bone marrow, prostate cancer, prostate gland, and pancreatic cancer, pancreas, melanoma, expert UV rays, melanocytes. And there are the various diagnostic techniques, imaging techniques, biopsy, and others. Coming under the imaging techniques, mammography, ultrasonography, endoscopy, MRI, PET, that's positron emission tomography. Regarding the biopsy, fine needle aspiration, core biopsy, excisional biopsy, incisional biopsy, and endoscopic biopsy. Then other treatments, bone marrow aspiration, tumor markers, cytology test, and the blood test. With these few words, I am also eagerly waiting for the lecture by our chief guest. Once again, I congratulate the zoology department, especially the organizing secretary, Dr. Shobana, Assistant Professor of Zoology. Thank you for the opportunity. I wish the program a grand success. Thank you.
Thank you so much, sir, for your inaugural address. Now, on behalf of the organizing committee, it's my pleasure and privilege to invite our Honorable Secretary, Madam, Dr. C. A. Vasagi, Secretary and Director of Konganada Arts and Science College, Coimbatore, India, to deliver the presidential address. Ma'am, please, ma'am.
Thank you. Good afternoon to all of y'all. I'm very happy to join in this webinar organized by our zoology department, and most esteemed, you have a very eminent and esteemed speaker for this seminar, Dr. Daniel Merrick of Genesis Care Oncology, Theranostics from Australia, faculty members, our research scholars who are present here to listen to this very thought-provoking lecture that is going to be given today. It is on Theranostics approach to cancer management. It gives me an immense pleasure to be a part of this program. As we all know, science and technology, the development has been mainly focusing on the welfare of mankind. it's not now, but always, any diagnosis, any therapeutics, it was always based upon, sometimes it is very solely for the needs and greeds, I would say, of this human race. So when you look into the traditional method, what we have relied upon throughout in our history, how it was treated, how treatment was gone, most of it was patient-centric, of course. And when it says patient-centric, it's always started with history taking, and then they have a relevant clinical examination, and then you arrive for the cause of the problem, you diagnose and plan appropriate management. This was what the management, it depends on different countries how it was done. Some countries used, like herbs and plant products were used for treatment, which later on, as we evolved, we tried to isolate the chemical components and chemical products of the plants, and they were used for treatment. So different modalities were used. So ultimately, everything was focused on patient care, patient-centered care. And later on, as we were evolving, it was like one medicine that fits for all came into existence. But now, the 21st century, now we are thinking that the approach of treatment should be more unique and custom-made drug therapy, which is based on interpersonal variation in drug response. So with that, we think this is it is something new, and it came up only in the 21st century, but not really. In India, thousands of years back, it was during the Vedic period.
Yes, ma'am. Yes, the
That every
மைக் கட் பண்ணுங்க மைக் கட் பண்ணுங்க மைக் கட் மைக் கட் பண்ணுங்க அது யாரு பாருங்க
டவுட் உண்டு
மைக் கட் பண்ணுங்க
நான் டவுட்
sorry I got
madam.
Yeah, when you see personalized medicine, it's not something new in our country during the period of from Vedic period. This has been practiced. And Charak Samhita, who is the father of medicine, and also Shushruta and Shwar from Australia. If you are from Australia, the Surgical Society in Australia, the statue what they have in front is Shushruta, and he was the first, they would say, the first surgeon. So how they practiced was, it is from their Charak Samhita, what he quoted, I will read. Every individual is different from another, and hence should be considered as a different entity. And many variations are there in this universe. All are seen in human beings. It is this is what was quoted by Charak Samhita, and how true it is now in 21st century. We are moving toward that same Vedic practices of medicine. So when you Theranostics is certainly nothing but diagnostics and therapeutics. And what is this objective? It is to render safe, very targeted, efficient pharmacotherapy by offering individual patients the right drug at the right dose in the form of theranostics as a part of personalized medicine. When you see from the period of Charaka, that is the Vedic physician of our times, of the Vedic times, and Hippocrates, all have practiced personalized approach for treating diseases. In 21st century, when we think about personalized medicine, it goes up to DNA level. So that's the difference, where we go into the molecular and even nano level. That's our approach at the moment in the modern 21st century. So, and how do we really apply it? And when you say, when you look into the Ayurvedic form of treatment, the Prakriti-based medicine, that is the Tridosha, just the three approaches they had, which was mainly it looked into the diet, that is what they called as ahara, and the vihara, which is the lifestyle, and aushadi, which is the medication. So this is the three approaches, approaches the Ayurveda had, which dates thousands of years. So the diet, the lifestyle, and the medication. Now, don't we think in modern medicine, that's what we are talking, your lifestyle changes. And when we look into most of our illnesses, which we face now in modern days, is based upon lifestyle changes. And when you look into it, now, the Theranostics is the right way, I would say, because it opens up a new vista in management, which is a three-dimensional pattern. That is, it blends diagnosis, treatment, and monitoring to response of the drugs. So this is also a tri approach, what would I say? So this not only Theranostics paves a way for holistic change from trial and error of medicine to personalized medicine, and contradictory to one decision suits all practices. Personalized medicine has revolutionized as a genuine interventional approach for custom-made drug regime based on variations between patients with respect to drug response, rendering increased safety and improved efficiency, I would say. I'm very glad that today the therapeutic approach on cancer treatment is going to be a very interesting topic. And we know this past 50 to 60 years, research for cancer and its treatment has been maximum exploited, but still there are areas which has to be addressed. And I think Theranostics would provide the answer to it. And thank you for giving me this opportunity for participating in this program. And I would like to conclude saying Theranostics has 4 P's as its foundation, which is predictive, and the second one is preventive, and the third is personalized, and the fourth one is participatory. And I'm sure this will provide solace to many people who are suffering out of the deadly disease like cancer. And I'm doubly sure that the speaker, Dr. Daniel, would be sharing much more experience in this direction, which would benefit all of us, our research scholars, especially who are quite actively promoting various anti-cancerous, who are working on anti-cancerous drugs, which is plant-based, because, you know, Coimbatore has a very, we are situated in the foothills of Nilgiri biosphere, which has a great biodiversity, and also a lot of medicinal plants are here. So thank you so much for giving me this opportunity, and good luck for this program.
Thank you so much, ma'am, for your inspirational and motivational speech. Thank you, ma'am. Now it's the time for introducing our today's chief guest, Dr. Daniel Merrick, Genesis Care Oncology, Australia. Now I request Dr. P. Kadareshwari, Assistant Professor, Department of Zoology, Kongunadu Arts and Science College, to introduce our chief guest. Ma'am, please.
Yeah. Hello. Good afternoon. Good afternoon to everyone. And I welcome our Secretary and Director, Dr. C. Vasi ma'am, and our guest, Dr. Daniel Merrick from Australia, and all our higher officials and participants for this beautiful webinar. I'm Dr. Kadareshwari, Assistant Professor in the Department of Zoology, Kongunadu Arts and Science College, Coimbatore, Tamil Nadu, India. It's my great privilege to introduce today's guest, Dr. Daniel Merrick. She qualified an AFRA registered medical practitioner with 18 years of experience in clinical medicine, medical advising, and medical affairs, and and also have teaching, research, and project management experience for last 15 years. She is PhD chemist and innovator in medicine and business leader in healthcare. She qualified PhD from University of Murdoch and a Doctor of Medicine from University of Western Australia. And she qualified person for drug discovery, development, and commercialization from University of California. She worked in different positions as senior scientist, dean, senior innovator, chief scientist, resident doctor in reputed institutions in Australia. She is in several scientific bodies like Australian Medical Association, World Association of Radiopharmaceutical and Molecular.
Ma'am, you're not audible, ma'am.
Royal Australian College, World Inaugural Winner Award, University.
Phone out.
Research Award, received Excellence Award, Research Excellence Award from different universities.
Connection issue.
Shobha, I think
Yes,
you
ma'am.
can do the introduction.
Yeah.
Okay.
You, Kadreshwari, and you please carry on with the introduction.
Okay.
See it, sir. See
Hi.
it. See it for you.
Yes, she has received many awards like inaugural winner, first among equals women in technology and STEM, 10 Seldom Prize in pathology, Max Kevin Prize in general practice, etc. She has published more than 100 papers in well-reputed journals in the area of theranostics, radiopharmaceuticals, molecular imaging, oncology, and material chemistry. She is the member of various organizations like Australian Medical Association, World Association of Radiopharmaceutical and Molecular Therapy, World Federation of Nuclear Medicine and Biology, Royal College of Physicians, Edinburgh, etc. She is also a chief scientist and principal radiochemist, Genesis and Oncology, Theranostics, Australia. So with this introduction, I hand over the session to the Dr. Danielle Merrick, Australia. Ma'am?
Yes, thank you very much, Dr. Shabana. Now, first of
Thank
all,
you.
can we confirm you can hear me? Yes?
Yes.
And great, and my screen, I hope, is visible.
Yes, visible.
Yes, visible, ma'am, visible.
Okay, that's very good. Well, look, thank you very much, Dr. C. Shabana, for the invitation to speak to you all today, and good afternoon to all of you, to the Honourable Secretary and Director, to the various participants. It's my absolute privilege to talk to you today and an absolute pleasure. And I must say I'm incredibly pleased to see how many participants we have on the list. It's very, very satisfying to me to see this level of interest in something that is very, very important to me and something I'm passionate about, which is improving the diagnosis and treatment of cancer. Now, thank you also for the very interesting introductory comments. I'm actually very interested to listen.
Dr. Danielle,
Yes.
it's possible to maximize your screen?
Make it full screen.
I'm sorry, I can't. I apologise, I can't do that because, oh, look, let me try, actually.
Oh,
Let me try.
No. Click the icon. Click on it. Dr. Daniel.
Better?
Dr. Daniel, can you please press the icon, which is make your PPT in the full screen? Please
Sorry, I
make
can't hear you. The screen that I am seeing is maximised. You can't see the maximised screen?
Yes.
Can't see it. How about now?
Excuse me, ma'am. It's not visible.
Yes.
yes, visible.
but not maximized.
Yes, it's enough, ma'am.
Okay.
Okay, you can proceed. You can proceed.
All right. So I was just saying that I enjoyed the introductory comments, and in particular the comments relating to the importance of, you know, lifestyle, diet, and other things in cancer treatment. And I think that they are as relevant today as they were thousands of years ago. And likewise, the approach to personalising cancer treatment. And I think perhaps that was something that has been lost over the years, and I think we're now regaining the importance and re-recognising the importance of personalising all therapies, but in particular therapies for cancer. I mean, I say that because that's of interest to me. I note also that there are many different backgrounds, as I said before, on this call, and I noticed the mention of medicinal chemistry and the search for medicinal agents from biology and from plants in particular. And I think that this will always remain a focus of pharmacology and of the search for therapeutic agents. Perhaps not so much at the moment in Theranostics, but I certainly appreciate that that's very important. So look, I'll move on with the presentation. As we've mentioned, I'm talking to you today about Theranostics, and as I've written there, this is an evolving treatment approach and also a diagnostic approach, mostly at the moment for the management of advanced prostate cancers. Today I'm going to talk to you about theranostic principles. So to give you some background on Theranostics, I'm going to talk about what I call PSA mania in the context of prostate cancer. And then I'll talk you through a few case studies and some of the important evidence in prostate cancer, some future perspectives and new approaches to Theranostics. Please let me know if any time, I can't see any of you or any of your icons, so if there is any problem at any time, please just interrupt me. So Theranostics began many years ago, 75 to 80 years ago now, by a physician by the name of Sol Hertz. He was an American physician, and he pioneered the use of radioactive iodine, I-131, as therapy for thyroid cancers. And in doing that, he exploited the natural uptake of iodine by the thyroid gland for the synthesis of thyroid hormones. He exploited that particular feature for the treatment of thyroid cancer. As you can imagine, if the thyroid takes up radioactive iodine, then that radiation is effectively a very targeted and internalized radiation directly to the thyroid that is then able to treat thyroid cancers. So that was the beginning of what we now call Theranostics about 75 years ago. Today we have a slightly more, or in fact a substantially more sophisticated approach to Theranostics, and I may be telling many of you something you already know, but the approach to Theranostics now is to exploit what we understand of the molecular biology of different cancers. And by understanding the molecular biology, understanding the structures of receptors, peptides, proteins, and other molecules that may be overexpressed by particular tumours, we're able to design and synthesize molecules that are in turn able to target those overexpressed molecular entities on the surface of tumours. And to those molecules that we design and synthesize, we're able to attach chemically diagnostic and therapeutic radioisotopes that allow us to image for diagnosis and also treat these cancers. So it's very much a sophisticated exploitation of what has become and continues to evolve a very detailed understanding of the molecular biology of a range of cancers. Now, as I've written there, this is not so much an approach for primary cancer or for localized disease, which is best treated by surgical and perhaps external beam radiotherapeutic approaches. But this is an ideal approach for disseminated disease, so for metastatic disease in particular. And as was mentioned in the introduction, what's very good and very advantageous about this technique is we're able to treat what we see in terms of the cancer, because we're able to visualize the molecular biology in the diagnostic phase. And we know that we're able to deliver therapeutic radiotherapy directly to those sites of imaged disease, where we see the overexpression of particular molecular features and molecular entities. And then following that treatment, we're able to very closely monitor the changes in that molecular biology. In other words, the decreased expression of those molecular entities associated with the cancer. And so by seeing, hopefully, a decrease in the molecular expression, we're able to know that our molecular targeted therapy has been successful. So that's the basis of Theranostics. Going back 75 to 80 years ago with I-131, which is still used today, of course, for the treatment of thyroid cancer, and then coming today to the sophisticated understanding of molecular biology and the exploitation of that molecular biology. So much of the work to date in Theranostics has been done in the field of neuroendocrine tumours, and in fact Theranostics is considered now a standard of care for the treatment of advanced neuroendocrine tumours. Theranostic agents for the treatment of neuroendocrine tumours are now approved by the FDA, and we expect that they will be approved around the globe in coming years. The next phase of development for Theranostics is in the field of prostate cancer, and this is where we do a lot of work in Genesis Care Australia and where a lot of my work is. I've given you some numbers here in Australia, but in particular, I really just want to focus on these proportionate numbers, which I expect would be the same in India and would be the same the world over. The important feature is that 25% roughly of male cancer diagnoses are prostate cancer. So you can see prostate cancer is a significant problem. Nearly 13% in Australia, and as I said, numbers would be similar elsewhere in the world. 13% of male cancer deaths in 2018 were accounted for by prostate cancer. But more importantly than that, 95% of men with prostate cancer are surviving out to 5 years now. So this is good. This is a very good prognosis. And this is because there are many lines of therapy now for prostate cancer. But what this also means is there are many men surviving out to 5 years who have exhausted all other lines of therapy. So they have exhausted conventional treatments, they've exhausted hormone therapy, and they need another line of therapy. And this is where Theranostics becomes very important. So just another slide here to drive that point home. So we have, over the years, an increasing 5-year survival for prostate cancer. We have decreasing mortality and, interestingly, actually decreasing incidence as well, but an increasing 5-year survival. So this means we need to find other lines of therapy for these men as their cancer becomes resistant to the currently available lines of therapy. Let me talk to you in diagrammatic form, I guess, just to reiterate what I've already told you and what many of you I know will understand. But this goes back to the point from my first slide. So we have a cancer cell that expresses, or hopefully overexpresses, a particular molecular signature or a particular molecular entity. To that molecular entity, we bind a molecule that we design and synthesize. Very often we need a chelating agent, and often that's a chelating agent called DOTA. Many of you will probably know DOTA. And then to DOTA, we're able to bind either a diagnostic radioisotope, so a positron, or a gamma-emitting radioisotope for diagnosis, or for therapy, a beta minus or an alpha-emitting isotope. Over here we have the structures. They won't be very clear to you, but these are a couple of PSMA targeting molecules that are used most commonly, not just in Australia, but around the world, in Germany and elsewhere, for the treatment or for the diagnosis and treatment of prostate cancer. And this is a man who has, as you can see, very widely disseminated metastatic prostate cancer, which is being imaged in this case by these PSMA targeting molecules. I'll talk to you a little bit more in a second about PSMA, but these are, I mean, this is the type of patient for whom this theranostic approach is most suitable at the moment. This is widely disseminated disease. This patient is likely to have failed currently available systemic therapy, so failed chemotherapy and failing hormone therapy and needing another line of therapy. So this brings me to what I described previously as PSA mania. So this is mania. There is a lot of activity in this area of PSMA. PSMA is what has been described by Professor Richard Baum. He is a German professor and colleague of ours. He's done a lot of the early work and the pioneering work in this area of PSMA for prostate cancer. PSMA is prostate-specific membrane antigen. It's termed prostate-specific, but in fact it is not prostate-specific, and we'll talk a little bit more about that in a moment. But this is a transmembrane glycoprotein. It's expressed in normal prostate epithelium, but in fact it is importantly upregulated and overexpressed in about 90% of prostate cancer. So it's expressed by the normal prostate, but also by prostate cancer in a significantly overexpressed way. What's more important is that for patients with poorly differentiated, metastatic, and prostate cancer that is broken free of androgen control, this PSMA is significantly overexpressed. So what that means is, if we go back to that previous patient with the image I showed you, with that widely disseminated disease, really terribly metastatic disease, we find that this PSMA is even more expressed. So that's very helpful for us in terms of theranostics and helpful for how we might treat that patient. As I mentioned, PSMA is also expressed by other glands and other organs. Most concerning for the theranostic approach to prostate cancer is that it is expressed by salivary glands. What this means is, and this will become more clear to you, I guess, as we move through the slides, is that there can be uptake of any radioactivity that we deliver through our molecules that we design to target that PSMA overexpression. That radiotherapy can also target the salivary glands. And so that is one of the areas of toxicity of PSMA-targeted therapy for prostate cancer. PSMA is internalized when we bind when the endogenous ligand is bound, or when any ligand we administer that also binds to the PSMA is bound. So it's internalized and endositized. Now, as I mentioned, because we have this considerable overexpression by metastatic and androgen-independent prostate cancer, PSMA is a really excellent target for the theranostic approach to prostate cancer. Now, I've shown you an image here on this slide, which you might wonder, it seems very unrelated to prostate cancer, and it certainly is, because this is a breast cancer. I wanted to show you this to demonstrate that while at the moment we do a lot of our work in prostate cancer, we also have the opportunity to treat other cancers because, as I said, PSMA is actually not prostate specific, and it is overexpressed by some breast cancers as well. And there is some work going on in the area of breast cancer and theranostic approaches to breast cancer diagnosis and treatment. So what happens in the clinic? So as we know, Theranostics is a combination of therapy and diagnostics. So in the clinic, a patient will have a PET scan, and in the introduction you heard mention of PET imaging, or for diagnosis of cancer. So a patient will have a PET scan with one of these diagnostic positron-emitting radioisotopes, so F-18 or gallium-68. Patient has a PET scan, and through that PET scan we produce an image, of course, and that image either confirms or doesn't, that the patient has disease that expresses PSMA. If we find that there is PSMA identified, the patient then proceeds to treatment with therapeutic radioisotopes, so lutetium-177 or actinium-225. Lutetium-177 is a beta minus emitter. Actinium-225 is an alpha emitter, very, very powerful, and has shown some very good results actually in this type of therapy. So we inject that to the patient. It binds to the tumour cells because it connects with the overexpressed PSMA. And we call this, by the way, the ligand PSMA, but in fact it's not PSMA. The PSMA is expressed on the tumour, but the ligand is a PSMA ligand, so a ligand that we designed that binds to the PSMA. It's connected to the therapeutic radioisotope. The tumour cell is irradiated, and then the patient goes through the cycle of, again, another PET image to see how the tumour has responded to the therapy. And the patient can go through this cycle many times. Most patients go through 3, 4, 5 cycles. Some patients will go through up to 10 cycles. And the reason they're able to go through up to 10 cycles over a number of years is because the toxicity of this type of treatment, because it is targeted very much to the tumour, the toxicity is limited. So this contrasts with other systemic therapies like chemotherapy, which are very good, but unfortunately, as you know, have in many cases quite significant toxic effects. So let's have a little bit more of a look at the PSMA-targeted therapies as a diagnostic. So this is in the context of the PET-CT. And for this, we mostly use gallium-68. At our centres at Genesis Care Australia, we use PSMA INT is the name of the ligand. I for imaging, diagnostic, T for therapy. What is also nice about this INT, as I've written here, is we can bind, I don't know how many chemists we have, but we're able to bind gallium for imaging, and then we change the ligand, we change the isotope to lutetium for therapy or other radiometals. So this ligand allows us to bind a range of different types of metals, different radiometals. So as I said, we image the disease with the gallium, we deliver the therapy with the lutetium. There are many papers looking at the use of gallium PSMA PET-CT, in particular in biochemically recurrent prostate cancer. So this is in patients who have had definitive therapy. They've had either surgery, so prostatectomy, removal of the prostate, or they may have had external beam radiotherapy. So they've had a primary therapy that is intended to be curative, but what is more or less, what is just, in fact, almost inevitably the case with patients who have had what is intended to be curative therapy, at some point down the line, many years later, they will have what we call a biochemical recurrence, which is an increase in their prostate-specific antigen, their PSA, sometime down the track. So there's a lot of work that has looked at the use of this type of imaging in that setting. We find it's a very sensitive imaging modality, particularly for very low PSA, so very early in the biochemical recurrence. And this is a massive improvement on traditional imaging techniques, so CT alone or bone scans, or nuclear medicine bone scan, for which the PSA needs to rise often above 5 nanograms per mil before you are able to actually image the disease. So this technique allows imaging at very, very early biochemical recurrence, and also with very, very small volume nodes. So 2.4 millimeter node is very, very small and is something that can't be detected on CT alone. So it's a very, very sensitive technique. So if we have a look at the comparison, this is a study that we did and that we have published in 150 of our own patients with very small, in many cases, biochemical recurrence, very low PSA, 0.04 up to 100, so that's a bit more substantial. But the important point is that overall, with the gallium PSMA PET, we detected lesions, we detected cancers in 68% of patients versus 42% only in CT. Now, this is not to say that CT doesn't have its use. What it actually says is we should be using this gallium PSMA PET-CT together with CT, diagnostic CT, for picking up lesions in patients with biochemical recurrence of prostate cancer. And you can see over here in this chart that in patients with a low PSA, we had a lot more detection of lesions for the PSMA PET. Likewise in the middle range, and of course also in a higher range, 1.5. So very important that we use this technique, which is, by the way, not available globally now yet. We of course anticipate that the FDA will register these products, and in fact we're working with pharmaceutical companies that are working on having these gallium PSMA targeting imaging agents registered for use around the globe. In primary prostate cancer, there is not as much literature, there hasn't been as much work done, but we also find, if you have a look, hopefully you can see my pointer here, and if you have a look at this graph on the right here, we find that at primary presentation, in many patients, we detect metastases at presentation that otherwise would not have been detected by conventional imaging. Now, this is very important because it guides therapy. It means that a patient that may otherwise have had just a prostatectomy or just external beam radiotherapy to their prostate, or maybe external beam radiotherapy to the pelvis only, suddenly we're finding that with this imaging technique, we're picking up metastatic disease in the form of, metastatic lymph nodes, perhaps outside the pelvis. So that means we need to change the therapy for that patient, maybe target those lesions that are outside the pelvis with external beam radiotherapy, or with our theranostic therapies. So this has become a very, very important imaging technique. Now, I'm talking here in the context of prostate cancer, but it's important to remember, I mentioned breast cancer, and you can imagine, and certainly we are working on other cancers and other agents, not just the PSMA targeting ligands, but any number of molecules that we can design and that we can synthesize to exploit the overexpression of particular molecular entities by cancers. This is just again to say, or to highlight the importance of using this agent at primary diagnosis of cancer, and in particular for what we would call high-risk cancers. So high Gleason score, we found the detection of metastases at primary diagnosis with the use of these PSMA targeting imaging agents by PET-CT. So very, very important that these agents become available globally. So here we have an image to show you an example. So this is a patient who had conventional imaging. And by conventional imaging, I mean CT and I mean bone scan, nuclear medicine bone scan. And on those images, there was a negative, the images were negative. There was no disease detected. The patient had a gallium PSMA INT, so a theranostic diagnostic scan, and you can see there is a very tiny external iliac node. There's also some disease over here in the acetabulum, and there is also some disease in the thoracic spine. So none of these, just to reiterate, were seen on CT, but very important to know for this patient that there is metastatic disease. And that in turn directed the therapy and the therapeutic decisions for this patient. So that's the imaging component. I'll talk just very quickly about the therapeutic component, then I'll show you some cases, and then we'll talk a little bit about the future. So mostly for therapy now we use lutetium-177. This has a very nice half-life for this type of therapeutic approach. So we inject this to the patient, and because it has a half-life of 7 days, that means that the therapy is having its effect for 7 days. Well, actually longer than 7 days, but it's something that continues over a period of days for the patient. For the chemists among you, you would understand a little bit about the chemistry of lutetium. It's not necessarily completely easy to work with because it has multiple oxidation states, but the chemistry is quite nice. We can work with it fairly easily. It's a beta emitter, so as far as its radiation properties go, this means it has a really nice therapeutic effect and it penetrates the tissue to quite a nice range, so 1 to 10 millimeters. So if you think about a cancerous lesion and a metastatic lesion, we can target fairly small metastases and get some pretty big ones as well, up to about 1 centimetre. It has a gamma emission also, so that means we can image the distribution of this agent once we've administered it on SPECT. And in Australia, we're able to offer this to patients, although this is not an approved agent, we can offer it on what we call a special access scheme, and I'm sure you have similar schemes in India. So we're able to apply to the government to say we have a patient who has used all other available therapies and they're able therefore to have compassionate access to this agent. So that's very good, and we've treated many patients, hundreds of patients. Probably not many by Indian standards, but certainly by Australian standards, that's a lot, and we're happy we're able to offer that to these patients. So a little bit more about the features just of that lutetium-177 therapy. So we're able to, as you're, I'm sure, really grasping, target the radiation therapy directly to the tumour. Because it is a direct targeting, there's minimal toxicity to other organs. We have a problem with the salivary glands that I mentioned, but the toxicity otherwise is limited. We have specific targeting, and this is variable. We're talking now about prostate cancer, but if we have other types of tumours that may express anti-CD20 or somatostatin receptors or other things, we can very specifically target them. We can determine the dosimetry. In other words, we can determine and calculate the dose of radiation directly to the tumour, and we can also look at the dose of radiation to healthy tissue and other organs at risk to make sure that we are really not delivering a toxic dose of radiation to organs other than the tumour. And the other thing we can do, and that we're starting to do increasingly, is we can combine this therapy, this internal radiation therapy, with other types of therapy for cancer. And in particular, at the moment, we're working on trials that combine our therapy with external beam radiotherapy, but we can also combine with chemotherapy, and other colleagues are looking at combination with chemotherapy, with hormone therapy, with immunotherapy, or natural therapies, with exercise therapy, actually is something we do a lot at Genesis Care. Very, very focused at the moment at how we can optimize the combinations of therapies. So some clinical practice, as I said, we'll have a look at some cases, and I don't want to get into too much technical detail here, but I suppose the thing to take away from the slide here of this case study is we have a patient, 63, so he's a young man. He's been through multiple types of therapy. He had a radical prostatectomy, so he's had his prostate removed. He had some pelvic lymph nodes removed. But unfortunately, his PSA began to rise after that definitive therapy. So as I said to you, unfortunately for many men, it's inevitable that they will have a recurrence, a biochemical recurrence. He had what we call salvage external beam radiotherapy to the prostatic bed, also to his pelvic lymph nodes. However, his prostate-specific antigen continued to rise. He didn't want hormone therapy, and he had conventional imaging, and all of those staging investigations on the conventional imaging were negative. He came then to have a theranostic diagnostic scan, a gallium-68 PSMA scan, and you can see here very clearly he had a metastatic deposit. So that allowed the external beam radiation oncologist to target that external deposit. So here we have a case where we didn't use our theranostic therapy, but the outcome of the diagnostic theranostic was able to guide external beam therapy directly to that metastatic deposit. So one way to use Theranostics. He went on, unfortunately, to have a recurrence in a lymph node. He still declined hormone therapy, he declined chemotherapy, he wasn't a candidate for surgery, and here is when we said, okay, now we will give him our internal beta minus lutetium-177 PSMA targeting therapy. We went on to give him that. He had only one cycle. He had an excellent response. You can see there is the node. I do hope you can see my pointer, but there is his metastatic node prior to his treatment, and post his lutetium-177 PSMA treatment, that node is no longer visible. And this gentleman, in fact, continues to be disease-free, just with one dose of lutetium PSMA therapy. Now that, I must say, is unusual, that he required only one dose and he continues to be disease-free. Many patients require multiple doses. Many patients don't become disease-free. In fact, all we can do often is control their disease, but which for many patients is in itself a good result. But for this gentleman, he had complete remission. Here we have another quick example. Now, the feature with this gentleman is he had been through multiple types of therapy back in 2001, long ago now. He had recurrence of his disease with the rising PSA in 2016. His biggest problem was he had stayed quite stable disease, but as you can see on this image, this is a gallium-68 PSMA image. He has multiple, sorry about that, he has multiple deposits of disease throughout his skeleton and throughout his body. These were causing him a lot of pain. And this is a strong feature of men with metastatic prostate cancer to bone. They have a lot of discomfort often. Unbelievably, this man had 2 cycles of lutetium PSMA. You can see he has no visualized disease. He still has a PSA, so it means he still has metastatic disease somewhere. But on his imaging, he has virtually no disease. And for him, the most important thing is that he has an almost complete resolution of pain. So he's a very happy very happy patient now. So a little bit about the side effects of this treatment. I've just shown you a couple of examples of response. Patients will experience lethargy, which is transient, by the way. It resolves very quickly. In some cases, they'll feel nauseous. In the case where they have pre-existing bone pain, they will often have a flare of that pain after the disease, and that's as the agent reaches the bone will have a flare response, which we can often control with steroids. Because the agent targets the salivary glands, they'll also often have a dry mouth. That's after each treatment. And then sometimes you can notice some marrow impairment, which again is transient after a number of treatments. And sometimes some very mild renal injury. And in fact, we've looked at our patients retrospectively, and out of maybe 150 patients, we might see 4 cases of very, very mild and transient renal injury. I want to just quickly show you, I'm noticing the time, but I want to quickly show you some more formal studies that have been undertaken. And this is a study from our colleagues at the Peter MacCallum Cancer Centre in Melbourne, Australia. This is the work of Professor Michael Hoffman, a close colleague of ours. He did a proof of concept study in 30 patients, so a very, very small study, but this was, in fact, the very first study in 2018 that was done, I guess, in a prospective manner. These were patients with biochemically recurrent metastatic prostate cancer, and they had, I think, 4 treatments, if I remember correctly, so 4 cycles of lutetium PSMA targeted therapy. The endpoint for this trial was the PSA response, and you can see that a large number of patients had a greater than or equal to 50% decline in their PSA, and this is significant. This is a very good response. Other patients, many more at 12 weeks, had any decrease in their PSA. That's at 12 weeks. Many patients throughout the study, in fact, only 1 patient didn't see a PSA decline at all. And if you look on imaging, these patients also responded on imaging. You can see a decreased burden of disease if you look at image B relative to A, and likewise image D relative to C. So that was a very good study. If we look at some of our own data, here again we're looking at PSA decline, and in our patients we do see PSA decline in just about all patients. And over here we can see that for patients that have been pre-treated with chemotherapy, their overall survival is not as great as patients who have not been pre-treated with chemotherapy. So this says something about where in the treatment algorithm we should really be placing this type of theranostic therapy. Just a little bit, this is a bit of a poor quality slide, I apologise for that. But what this shows you is that patients who over here have disease in the lymph nodes versus the bones, they tend to have a longer survival time once they're treated with this therapy. So lymph node disease tends to be more responsive to this therapy than bone disease. These are patients who are re-challenged with actinium therapy. I'm going to go to that in a minute, but they survive longer. And down here we have, we did a comparison of our Australian and European data. That's not important. Very quickly now moving to actinium therapy. So I mentioned you before, actinium-225, this is an alpha-emitting radioisotope. And you can see here a very, very just remarkable response. On the left here we have a patient with a very heavy metastatic burden in the soft tissues of metastatic prostate cancer. This patient has a PSA of 420, was treated with 2 cycles of actinium-225 PSMA targeting therapy, and you can see just almost complete resolution of disease and a drastically almost undetectable PSA. This patient on the right has not so much soft tissue disease, but you can see widespread disease in the bones and a PSA of 3,000 and almost complete resolution of disease post 2 cycles of actinium-225 PSMA. Now, we don't know much on the toxic effects of actinium-225 therapy. There's a lot of work to do, but I hope what you're understanding is that there is significant hope with these alpha therapies. And here we have a study from our colleagues in South Africa. Now, what I really just want to show you is this was a small number of patients, only 17 patients, but these were very, very advanced patients, very, very sick patients treated with actinium PSMA, and in fact, their disease almost completely regressed. Now, these are, I have to point out, end-stage patients with very, very limited prospects in terms of recovery, who are responding extremely well to this type of theranostic therapy. So we have some work to do looking, as I said, at how we can predict, and somebody mentioned in the introduction, the use of Theranostics as a predictive tool, and we can certainly do that to some extent because we're able to visualize disease, but we need to work a little bit harder on how we can predict which patients will respond well to this theranostic type of therapy and perhaps which patients will not. I've shown you some cases of patients that have responded very well, but it's important that I point out some patients don't respond nearly as well, or they have a transient response. Other patients don't respond at all. So we need to try to predict, come up with some tools to allow us to predict. As I mentioned, we need to consider where we put this type of treatment in the treatment algorithm. At the moment, we do it post-chemo, post-external beam radiotherapy. We need to really look hard to decide if, in fact, we should be offering this therapy as first-line therapy. As you can imagine, there are trials looking at that. We need to, as I said, understand how this works in combination. We need to do more prospective trials, and we need to think a lot about how we do the dosing. This slide shows you, it's awfully messy, but I guess what I want to show you here is that there are now many prospective trials looking at this type of therapy. These are randomized controlled trials. They are now sponsored by pharmaceutical companies. And we are approaching a point where these types of treatments will be approved by the FDA and other international regulatory agencies. I mentioned other types of tumour. So there is work happening. This is a company we work with, Clarity Pharmaceuticals. They're looking at this type of approach for neuroendocrine tumours. I mentioned that there's already an approved agent for the treatment of advanced neuroendocrine tumour. Clarity are working on an alternative, perhaps an improved agent. They're also doing a lot of work in children, so neuroblastoma in particular, and that agent is currently in trial in the United States. They have an agent for prostate cancer that will soon be in clinical trial also in the US. And they have what's called a pan-cancer agent, a bombesin agent for any type of cancer, which is very, very promising. Here is another agent. It's a fibroblast activator protein inhibitor. This is another alternative or another potential pan-cancer agent. We won't go into looking at the images, but I guess the point I want to make is this is a rapidly evolving area with many different groups, many different academic institutions, many different biopharmaceutical companies and biotechs looking at developing agents that can target a multitude of cancers by exploiting that molecular signature for diagnosis and for therapy. Again, to just show you, there are trials happening. So these are trials we're involved in Genesis Care. And I have to tell you and apologise, this is a little bit out of date because there are many more randomised control trials happening now. And even if you were just to Google Theranostics clinical trials, I think you would come up with many. The agent PSMA, just to return to that, I mentioned that there are other cancers that it has relevance to. So prostate cancer is one, breast cancer is another, and glioblastoma is another. Now, many of you would know that glioblastoma is unfortunately a cancer with very, very poor prognosis, sadly, very poor outcomes. We can use PSMA to image glioblastoma, and we hope also deliver therapy with lutetium PSMA. In fact, we've done it for 1 or 2 patients, but we have colleagues working at developing alternative agents to PSMA targeting ligands for glioblastoma, and we have a lot of promise there. So that brings me to the end. I hope you've come to appreciate that at least in the context of prostate cancer, we have a very rapidly evolving paradigm in terms of gallium PSMA imaging and lutetium 177 therapies for prostate cancer. It's fast becoming an established paradigm. We expect it will be an FDA registered agent very soon. At the moment, we have a lot of data in end-stage disease for patients who have exhausted conventional therapies, but we hope and we believe it will be true that this agent will become a first, or perhaps not a first, but a second-line therapy for patients pre-chemotherapy in years to come. And that's because it has decreased toxic effects, because it is highly targeted. For patients who are in stage and perhaps don't respond, as I said, we're finding that they have significant improvement in their clinical symptoms. So for end-stage patients and palliative patients, we're able to improve their pain. So that's very important. As I mentioned, the side effects are very minimal. Most patients tolerate this very well. We have been able to confer a substantial survival benefit of up to 40 to 46 months so far in heavily pre-treated patients, and we think we can improve upon that in patients that are not heavily pre-treated. We have many, many opportunities to develop other agents for other cancers and to really improve patient outcomes in we really believe in a patient-centered approach. We believe in decreasing toxic effects. We believe in quality of life for our patients and to have them living productive, really satisfying lives for as long as they can while they're undergoing cancer treatment. And in fact, our goal is that cancer is a chronic disease for patients and something much like diabetes that they can live with. And we think with these types of targeted treatments, we can do that. We want to look at how we can apply this theranostic approach for low survival cancers and for other cancers where currently there really are very, very few treatments. So here we are talking cancers like glioblastoma and others. So that brings me to the end. I thank you very much for your attention, and I've stopped sharing my screen so I can come back and see you, I hope. I see that everybody is still here. So thank you very much indeed, and I invite questions. Dr. Shabana, if there are any questions from anybody.
Everything.
Thank you so much, Dr. Danili.
Thank you for having me.
Thank you. Now the session is open for discussion.
Any questions?
Audience are requested to chat your questions in the chat box. If you have any queries or questions, you have posted in the chat box.
I see all the comments coming through. The thank yous, you're absolutely welcome. My pleasure and my privilege to talk to you. So there is a question coming through. Is there any new research? So a lot of research now is, as I mentioned, in these pan-cancer agents. Agents that treat not just a specific cancer, but that can be used for a wide variety of cancers. There are many agents in development. There will be clinical trials. If you watch this space, I think you'll see a lot of development in these so-called cancer agents. I see a question here. Is a theranostic approach applicable to COVID-19? Excellent question. And yes, there is a study underway. I'm afraid I can't cite the authors or the group, but if Theranostics for COVID-19 or radioligand therapy for COVID-19, you'll see there is a study underway. Yes, because it's possible to target that that inflammation. So that's a very good question. Good books about PSMA Theranostics and any research. I can't think of a textbook, but look, there are so many papers, and this is why I call it PSMania. So if you were to just go into something as simple as Google Scholar, there are some very nice publications. Stefano Fanti, F-A-N-T-I, has produced a nice publication which summarises where the current status really. You'll be able to just get a nice summary. And I'm happy to, Dr. Shabana, if you like, I'm more than happy for you to give my email to anybody. And I'm happy to correspond and also send through some articles and interesting pieces of information, even some more images, anything that anybody would like. I'm absolutely happy to share, Dr. Shabana, so you're welcome to share my
mail ID share kindly share your email address in the chat box.
Okay.
Okay.
Do so. You can use, let's use this one. Okay, you can see. I'll also give you my other one.
Okay. We'll send you by your email.
Two email addresses there for you to use. You can use either one, but I'm welcome to keep the conversation happening via and happy to answer any questions that people have over the coming weeks. Please contact me anytime.
Okay. Sir. So if it is any questions from the audience, now it's the time for delivering the vote of thanks. Very good afternoon to everyone gathered here. I am Dr. Sri Shobana, Assistant Professor, Department of Zoology, Kongunadu Arts and Science College, Coimbatore. On behalf of our management and organizing committee, I'm happy to deliver the vote of thanks of International Virtual Guest Lecture on Theranostics Approaches to Cancer Management, organized by Department of Zoology, Kongunadu Arts and Science College. First, I would like to thank our Honorable President of Kongunadu Arts and Science College, Dr. Orichami Sir, for his blessings to conduct all the activities carried out in our college. I am very grateful to thank our Honorable Secretary, Madam, Dr. C.A. Vasugi, Secretary and Director of Kongunadu Arts and Science College, for her encouragement and motivation and constant support to conduct the webinar in a successful way. Next, I would like to thank our Principal, Dr. M. Laxmanaswamy, Sir, for his motivation to conduct the program in all possible ways. I would like to convey our special thanks to R&D Dean, Dr. Palsamy Sir, Academic Dean, Dr. Madan Sangar Sir, Chief Executive Officer Dr. Chinnuswamy sir, and Controller of Examination Dr. Murugesan sir for their encouragement. Next, on behalf of our management and our department, I extend our heartfelt thanks to today's chief guest, Dr. Danielle Merrick, for her wonderful lecture on Theranostics approaches on cancer management. Madam has explained the various diagnostics techniques, principles, method, imaging, side effects and their toxicity studies, and new approaches in Theranostics. Really, it was very useful and highly informative session, ma'am. We hope surely our participants, especially our students, are benefited more and gathered more knowledge on this special topic. Thank you so much, ma'am.
Thank you very much indeed for the invitation, Dr. Shabana, and to participants. I appreciate it. It's a pleasure.
I also thank the convener of the program, Dr. S. Dinukumari, HOD in charge, Department of Zoology, Kongunadu Arts and Science College, for her moral support. My special thanks to all our department faculty members for their support in all possible ways. Last but not least, my sincere thanks to all the participants for their overwhelming responses in a short period of time. In this webinar, nearly 700 participants were registered. So due to the technical issues and limitations, 250 participants were entered. And I thank all the participants from our institution, other institutions, research scholars, and students for their kind support. So on behalf of our management and department, I record my sincere thanks to all of you. Thank you so much. Thank you.